Ok, es un honor estar con ustedes otra vez. Como bien saben, mi nombre es Víctor y vamos a continuar con las preguntas para el profesor Paolo Valerio. En este momento vamos a tocar dos temas que consideramos fundamentales para la psiquiatría actual en México. El primer tema es la importancia de la psicodinamia o el enfoque psicodinámico en la formación de los psiquiatras o en su práctica terapéutica. Y el segundo tema, que es la especialidad y el mayor tema de vanguardia del profesor Paolo, es el género. Entonces, bueno, nos vamos a encontrar con una información bastante importante, relevante y novedosa. Ok. Thank you, Paolo, for being here with us. Okay, the first question is going to be, what do you recommend for the psychiatrists that they are studying the residents or maybe the young psychiatrists about the psychodynamic approach? It is necessary, it is helpful, it is useful. What are the advantages of it? What are the disadvantages of it? Could you tell us a little bit about it, please?
Yes. Well, first of all, thank you for the opportunity to be with you. When we speak about psychodynamic approach to the patient or psychodynamic approach to psychiatric practice, we do not really mean that a psychiatrist should become a psychoanalyst. But I think that a psychiatrist should know enough in order to help the patient to cope with his symptoms. What do I mean? Of course, science demonstrates that it's not important a model, but it's important the relationship. This means that not important if you are a psychoanalyst, a cognitive, or a relational-oriented psychiatrist or psychotherapist, but what kind of relationship you establish with your patient or with the person that apply for your help. Because also people sometimes may need the help of a psychiatrist in order to cope with some emotional stress. And symptoms should be considered something very important in order to make a good psychiatric diagnosis, but should also be considered a key that helps us to understand what's happening to the person. I mean, symptoms could be also the expression or the solution that the patient found in order to cope with the mental pain that is at the base of his symptomatology. So symptoms are a solution, even if it's sometimes a very painful solution, in order to avoid more painful conflicts. So what I think is that a psychiatrist has to know, of course, psychopathology, second, psychopharmacology, and third, how to cope with relationship with his her patient, or with the person who applied to his her for help. Maybe an example could help us to understand what I mean. I was a very young neuropsychiatrist. As I told, my career started in Italy when there was no distinction between neurology and psychiatry. And there was a lady who came with a very severe rupophobia. She continued washing clothes of the husband and the children, often. And she was very resistant to therapy, to psychopharmacology therapy. Then I started, in those days, I started my training as a psychoanalytic oriented psychotherapist. And I started also to understand something more about the importance of speaking to the patient and of trying to give a meaning to the symptoms, because symptoms being a solution, an important solution, also need to have a meaning, not only from the neurological or neuroscientific point of view, but also from the dynamic point of view. And I started speaking with the lady, asking more about her history, more than before, going also further to symptoms and so on. And what happened? She started speaking about cancer at the uterus that has been operated, and by which she was operated about a few years before. It shocked her a lot. And also she told me that after that, she and her husband did not have any more sexual intercourses, because no doctor explained them what they could do, what they could not do. And they were very ashamed about speaking about sex with doctors and so on. So they thought that there was a hole in her body after the tumor was taken out, and so it was not possible to make any sexual intercourse. And once they told me that everything happened after an episode. The laundering machine was broken, and the lady in the building, she offered herself to clean the trousers of her husband. And after that, she told me, I don't know why, but something happened, and I started washing all clothes, and started trypophobia. I was very young, so but maybe this is linked to this. Maybe the fact you do not have any sex intercourse with your husband is a problem for you. No, I am no problem. I do not think my husband can do anything with any lady and so on. Okay. Then she came for the control after 2 weeks, I remember now. I remember that she told me, see, doctor, then I was a doctor, I'm a doctor. She said, doctor, I thought about what you told me. I started thinking, I must say that I really felt that not doing sex intercourse with my husband was something very painful for me, and also that I was afraid that he could do something with other women. And after this, I started speaking with my husband about this, and asked the medical doctor if I could have sexual intercourse. He told me, yes, you can have sexual intercourses. And we started having this sexual intercourse, and I started feeling a little better. I'm not doing so much washing of clothes on my husband's washing of my husband's clothes. Well, it was not a miracle. It was just offering that lady a space for thinking, a space for getting in touch with unthinkable thoughts, those thoughts that sometimes we do not dare we do not accept with ourselves. So, what I mean is that it's very important to spend, to offer time to patients to speak about themselves, about their symptoms, because drugs are very useful, because the diagnosis is very important, but also it's important in relationship. And for medical doctors who work as psychiatrists, work in this field, what is it's a field of pain, sorrow, it's important also to be helped in order to have a space where emotions can be expressed. I remember once during the training, I was professor of clinical psychology for the residents in pediatrics. There was a group of young students in the first year, and they were in the training as with me was based upon a sort of buying group. I mean, they had to report important experiences they had during their training. And once the experience they took was they were in terapia intensiva neonatale, I don't know the English for that.
Intensive therapy for neonatal.
Yes. And a lady was giving birth to, she should give birth to a baby, but the fetus was born dead, was put in the bucket of fetus dead. Then the fetus started crying, and they had to take the fetus out, and the baby, and someone told them, well, now you should do some respiratory rehabilitation. Do it, but not too much, because we do not know what kind of damages this baby could have from the brain point of view, owing to the long time without oxygen. I mean, students were crying, and also felt very unhappy because they were in the conflict. What to do? Do what the guideline told respiratory rehabilitation and as a baby with very severe brain damages, or let him die. We were in conflict. And we started thinking about this. I told them, you see, I feel as if you are, this happened many years ago in Baghdad, where our soldiers go to give peace, but they are terrorists. And with terrorists, or you kill them before they kill you, or they kill you. So, what's the metaphor? And working in this field is a very dangerous one. And then I asked them, how you can do a good work of policeman in the city of Naples after having had this kind of experiences and more? How you can do a good work as a pediatrician with the mother who has problems with the child who does not sleep, who does not eat enough, who is lazy and so on, when you have this kind of experiences? What kind of defense you need to use in order to survive emotionally to this very stressful experience? Going back to the example of the umbrella, defense mechanisms are an umbrellas help us to cope with emotional stress. But if the stress is continuous, endless, burnout, an umbrella can protect us from emotional stress. And so the problem is how to cope with this. Because pediatricians, psychiatrists need to have very deep technological knowledge. But also they have to be trained how to get in a good enough relationship. And we know that to cope with pain means you have to put gloves, very, very strong. But then you have also to take out those gloves, because if you want to do the work of someone who repairs watches, you can use those gloves. If you want to get in touch with the emotional stress of patients after the diagnosis, for instance, the emotional response to the diagnosis, or if you have to work with patients with psychotic problems or emotional problems. I mean, so we need both. We need technique knowledge, but also we need the knowledge of how to be in a good enough relationship. It sometimes may be helpful to work in group and sharing emotions and help the student to express emotions in order to be a good enough psychiatrist.
Thank you for that. So yes, the psychiatry should be with lot of tools, so this professional specifically can cope with all these big certain situations that they will know before, right? Sometimes bioethical, sometimes personal. Okay, so psychodynamical approaches give you more, right? That's kind of
You
a
see,
tool,
um,
a powerful
now
tool.
I remember another biographical sketch, I would
Please,
say.
please.
My mentor, he was very sick, and he went to the funeral of a good friend of his who committed suicide because he had a cancer. My mentor was also sick, and we were going to Bologna for a conference on medical patient relationship. And he came, he had a something on lung, so he came all red and told me, "Oh, Paolo, what a pity that we have to die." I told him, "Oh, Gustavo was in it. Don't think about it. Why you think these sad things and so on?" Well, I was an expert of communication, but in that situation, I replied like that. We arrived at the conference, and he started saying this. I imagine the patient looking with some pietà, with some commiseration to the doctor who are speaking with him of everything about phlebotolysis therapy and so on, but who do not speak about the most important thing for the patient. And what is the most important thing for the patient? Speaking about his own death anxiety. And then before, but how can doctors speak about the patient's death anxiety if very often they choose this profession in order to avoid think their own death anxiety? I felt really shocked because I have done that with him. I did not give him the space to say, "Oh yes, I understand, you are very sick and you have gone to the funeral of a friend of yours who committed suicide for a big bad disease." And so I mean, doing some listening, doing some help of my mental part. I was so anxious about the fear he could die that I made a sort of denial of this. So even if you are trained, you can't avoid this sort of mistake. So when we speak about this kind of replies, I think it's not a mistake. Doctor or psychiatrists are not making a mistake if they do not listen enough to the patient. But we can consider this the way, as a symptom, is the way how a patient, the solution the patient find to avoid emotional stress, emotional pain. So any kind of behavior that a psychiatrist or an oncologist use in order to cope with these issues is a solution that this mind found in order to escape to a big earthquake as is the communication to a patient of his cancer or of bad disease.
Thank you for that. Yes, it's kind of paradoxical, kind of sublimation that the doctors have. All the concepts you've been giving us, the narcissist, and all the might be a tool, might be an armor, might be mm, your worst enemy. We don't know. We're fighting the death, or we are like trying to avoid the reality of our own mortality and things like that. Okay, but thank you so much for this part. But now, the best for me and I think for many of us, please talk about gender, please, Professor.
Gender issues and surrounding, we can say. This means what was considered once gender dysphoria. Now we always more and more often speak about uh, transgender people and gender non-conformity. I mean, or gender incongruence seem to do ECD-11. So a lot of work is done in order not to stigmatize transgender people. But the work is never enough, because always there are some problem linked to stigma. When I speak about stigma, I speak about the product of a very dangerous couple. The couple is stereotype and prejudgment. Stereotype means that I take into consideration one quality or not quality of a person and extend to all the people who are all the category. For instance, I live in Naples. Naples in the Spanish quarters, yes. The area in Naples has been a Spanish colony, as was Mexico. So we had the same king, Charles III, and we have Spanish quarters, where often people can be robbed. Stereotype means that if I go to Verona, north of Italy, I see that I'm a Napolitan. The fact that I see that I am a Napolitan, the stereotype is that I am considered someone who could make something wrong. I could make something against law. And prejudgment is that even if they do not know me, the only fact that I am a Neapolitan put me in the position to be stigmatized. I mean, this means I lose all the quality of being a human being. This is what happened in Germany during the Nazism, when for stereotypes and prejudgment, Hebrew, Rom, homosexual, disabled, people with mental diseases were sent to death because we're not considered anymore human beings. This is why in school students can make homophobic or homotransphobic bullying to other colleagues because being in a category of people stigmatized give you the authority to do this. So one of the most important things nowadays is not only to continue the fight in order to depathologize the transgender condition. That is no more considered a pathology from the point of view of the ECD-11. It's still put in the group of mental diseases in 5
Yeah, 5 chapter is no more there.
No, in the DSM-5, and if it is and if it's still considered as gender dysphoria, it's because in those countries where private insurance have to pay for intervention, if you are not yet a diagnosis, you can't do anything. But I mean, so we have to fight against the pathologization in order to depathologize the condition. But also we have to fight a lot against stigma and against stereotypes. And the first most important thing to do this is culture, is to train students in school, train students at university about issues linked to sexuality, gender identity, sexual orientation. I live in Italy. And very often people say that the Catholic Church is homophobic. I say it's not homophobic. It's sexophobic. Because if a couple, husband and wife, want to have sexual intercourses non taken care of, for not having a child, well, they are doing a mortal sin. So the problem is that we should start training in this issue and to fight uh, what is now very well studied, the concept of minority stress. What does it mean to be part of a minority as sexual minorities? I may say that if I am a boy with black skin and I am in a class of boys with white skin, they could bully me. But if I go back home and they say this to my father, say, "Oh, don't take care of those stupid white boys, you are black, black pride," and so on. But if you are gay and you are bullied because you are gay, and you go and say to your father, your mother, well, you say, "Oh, let's go to psychologist, what's happening?" So the problem is how to really change the attitude towards this. And I was speaking about stigmatization. This is the worst thing because in Italy we have now the possibility of same-sex not marriage, unione civile, civil union, but still what I consider the hate speech is not punished if it is about gender identity or sexual orientation. So one of the most powerful stigma is what is considered the institutional stigma. The stigma linked to the, the absence of laws that protect people in order not to be under persecution. Because one of, in my experience, we work with, we have a gender clinic and often parents come for adolescents. And they say to me, "Oh, professor, gay yes, trans no." Why trans no? Because male-born M2F, I mean, boys who are sent as boys and girls, but who feel to be girls, have very few opportunities to be in schools because they are sent out very, very quickly. And also they have very many difficulties to find a job. So very often they are compelled to be sexual workers, not because they like it, but it's the only possibility that our society offers. And so we have to work a lot in order to let people understand that a difference is not something that should be cancelled, but could be an opportunity. Remember always something that could be interesting to share with you. We have a center at Naples University where we have a service of anti-discrimination, a culture of differences, with a site www.bullimomophobia.it, and many parents come and ask for help. Once came a couple from a small village near Naples, uncultured. They were distressed because the son came out and wanted to introduce the boyfriend at home. The mother came in my office crying and saying, "Professor, I do not understand anything anymore. Before you went with a woman, now you go to a man. He's still man or became a woman?" So she did know very well the difference between gender identity and sexual orientation. And also she was under the taboo of the feminization of man. Because a man, who is not viral or want to go to the man is considered second-class man. The father, oh, professor, they want to kiss. What? So let them explain that it was an emotional relationship. But they were not ready. So I thought it was useful to do a mediation with the son. I told them, well, let's meet with your son next week and let's speak about this. Next week they came. The son was 22, 1 meter and 80 centimeters tall, large bird, soldier, military soldier. I told them, well, I asked me, see, what's the problem? Oh, we have to cure him. I told them, I cannot cure him, not because I am not good enough psychotherapist, but because if I would cure him, the ortho psychologist would cancel me from the order because the reparative therapies are considered very dangerous. So we spoke about this. At the end, she told me, understand, it's not possible to do anything. I say, yes, madam, but why do you say that? You see, professor, putting the hand on her hand, it is a problem of sentiment, a question of love, sentiment. So this uncultured lady, when was offered the possibility to understand more about what was happening to his son, she could accept it. So I mean that culture is the most important thing to use in order to fight the widespread stigma against sexual minorities as are gay, lesbian, transgender, and intersexual, because we do not speak enough about intersexual boys that are a very high number. Statistics say that they are the same number of people with red hair that you know, so you can understand how big a number is. And you live in a country, Mexico, that had to cope with these issues after the colonization. I think that you have seen sometimes the horrible prints of the 16th century sodomites, because this was the word used before, sent to death with dogs from the Spaniards, Catholic priests. I mean, and you have the example of mushes. This means that it's natural. Is not linked to this time, because often people say, "Oh, why so many in this time?" The phenomenon of someone who was born with the sex but did not feel the same identity linked to sex and but felt something different. Who exists? In Naples, we have femminili. In India, you have heroes. In Thailand, you have Katoyo lady boys. Fafafine in Samoa Islands. So the importance is to let people understand that differences are always a resources. And in a multicultural and multi-ethnic society, as Mexico is, this is a very important, very, very important thing.
Thank you so much for that, Paolo. Professor Paolo, yes, it's a lot of things, and that is very important for us. Like Mexico is getting more openly, more the generations, they are changing, the millennials, the alpha, they want to know more about it, they want to take care, to be inclusive, okay, to protect each other. So yes, as you say, we need culturalization, we need to know what is this we're talking about, what is this changing, or actually they are changing, as you say, they might come from tradition, in some places, even in Mexico. Many people from here, they don't know just for the end of the...
I mean, the real risk could be in a period of social distress as we live now, the change of politics. What do I mean? In the end of in around 1890, Ivan Bloch, a German scientist, wrote a book about sexuality, and in this book was a chapter that was called "The Mystery of Homosexuality." And it's interesting because homosexuality was a very new word for those days. Before, the word was sodomites, and sodomites were sent to death with fire. And also it's interesting that after the French Revolution, it was for the first time that people who liked same-sex relationship were not to sent to prison, to death, or to mental health places, because all crimini di opinione, opinion crimes, were considered no more something that should be fine. Eresia, magia, and sodomia. So in this chapter, Christian Bloch writes, as far as my studies and my knowledge is concerned, I do not find more psychopathology among homosexual people, when homosexual was sort of the big umbrella, considering also transgender and so on, than among heterosexual. And if this happens, it's because the social reaction, the social response to the situation. So you already knew the concept of minority stress. But then what happened with the Nazi fascism? All the research of the Institute of Sexology in Berlin, run by Hirschfeld, was completely destroyed. And we needed 20 years more in order to start thinking about these issues, not as a pathology, not as a disease, but as a condition of life. So politics can also influence science. And we must be very careful in these days where the social pressure could evoke someone say, now I am the liberator and all these issues should be not considered anymore.
Oh, thank you for that. Yes, it's not, it's, I must say just for my part of conclusion that all the information you gave us, we think about like this kind of a health topic, but as you said, it has to be with cultural, it has to be with political, and it has to be like a trans or interdisciplinary approach. That's the way we should go, right? Like not be in our crystal castles talking about things that we look from one side of the whatever it be. So yes, like try to make this combination, make these liaisons, right? Okay, but thank you so much, Paolo.
Thank you for the opportunity you offered me.
Muchas gracias a todos y bueno, pues esperemos podernos ver pronto. Gracias.